Prof. Andrea Biondi, very well-known figure in the field, and he is a professor and director of pediatric department, as well as the head of the pediatric residency program at University of Milano. He's also, of course, the head or chairing the International BFM study group. Also, he's a scientific director of Titamanti Research Center. He has been leading in the past the SIOP Europe and as well as the AOP group. His focus, of course, in research and molecular characterization of ALL in children, and everybody knows him, published many articles that we refer to. So the Prof will be happy to hear you talking about Ph positive ALL.
Well, good afternoon and good morning. First of all, many thanks to you for the very nice words of introduction. And thanks again for the Saudi Society for Blood Disorders for the invitation. Although it's a real pity that it's not face-to-face, but it's still virtual. But I hope that in the future to have the chance to visit your country and as well your centers. So the aim of my presentation is just to share some of the topics related to a relatively rare disease in children and adolescents, which is the Ph positive ALL. And I will try to organize my presentation by just dealing with the lessons from the clinical trials. What are we doing? What are still the open question? And two major questions are, of course, what is the best chemotherapy backbone? What is the best TKI to be used in children and adolescents, even based on the adult experience? Finally, can we replace chemotherapy backbone? And it's going to be the next future, even for the pediatric world. Finally, the role of transplantation, and if we'll have time to discuss briefly, an entity which is something, I would say, probably unique to the pediatric field, which is the so-called CML-like Ph positive ALL. First of all, as I already said, Ph positive ALL is relatively rare subset. We are dealing with between 2 to 5% in different, according to age, from 0 to 18. Of course, if you include into the Ph positive ALL the newly defined Abelson class fusion, definitely we are dealing with probably double the incidence of this disease, but still we are dealing with a rare subset which before the TKI area has been associated with a very dismal prognosis in the pediatric setting. And even now, with respect to the very important results with the TKI in chemotherapy, is still the prognosis is still inferior to all other genetic subsets mostly occurring in pediatric ALL. This is just to give you the landscape where we came from before the TKI area, and thanks for the incredible cooperation which I believe is sharing around the world, that when you have a rare subset, you need to cooperate if you want to get as fast as possible answer to your question. This is just the results of the largest retrospective study which has been organized through this network, which is called Ponte di Legno. Ponte di Legno is a mountain venue in Italy, very nice, which basically hosts the first meeting of this international network, which is still keeping the name of the first meeting more than 25 years ago. And as you can appreciate, before the time of the TKI, even according to the different age, you see that the prognosis of this disease was still very dismal. And more important to your attention, that as you can appreciate, most of the children underwent at that time, before the TKI area bone marrow transplantation, after the initial course of induction and consolidation. But this has completely changed the landscape, and TKI changed the landscape even in the pediatric setting. Of course, we are dealing with a rare and accordingly a limited number of studies, and in this very nice review by Steve Unger group, you have probably the most important study which brought to the registration of firstly of the imatinib and later on of dasatinib, even for the use of pediatric Ph-positive LL. This is the first study which has been done a long time ago by our colleague of the Children Oncology Group, that clearly demonstrate that the cohort 5, which basically was a cohort of patients who did receive, not continuously, but to the largest extent, the TKI exposure, was basically the cohort of patients who did achieve the best prognosis as well compared to the bone marrow transplantation, opening the path to the use of the TKI plus chemotherapy as a substitution of stem cell transplantation in newly diagnosed children and adolescents with Ph-positive LL. And this is the results of the European consortium, which is within the IBFM and is called ESFOL, European Study Ph-positive LL, that took the challenge, differently from our American colleagues, to address the question in a randomized manner, to give a TKI at the end of induction and to see whether the impact of the TKI can really change the landscape of this type of disease. And it has been done, as you can see the results on intention to treat analysis, which clearly show that the imatinib, even in a context of large use of stem cell transplantation as a consolidation step, we are talking about the early 2000s, and at that time it was a paradigm in Europe as well in US and Canada to use stem transplantation as a consolidation tool for patients with Ph-positive LL. This has been confirmed even with a long follow-up, but again, in these two preliminary studies, which basically brought to the registration of imatinib for Ph-positive LL, the imatinib at that time was given after the end of induction. And of course, this was completely changed when, based on the findings in the adult setting, we realized basically that as early you give the TKI, as better you can achieve the quality of the remission, even in terms of molecular remission. And this, of course, was the results of the subsequent study, which clearly demonstrate, as you can appreciate by this cartoon, the comparison of the quality of the MRD remission, molecular remission, whether it was when the TKI was given at the end of the induction A or at the end of the induction B, highlighting the concept, which was very well known in the adult setting, that as early you provide the TKI, better is the quality of the remission and accordingly the strategy to be used. But of course, imatinib was the first TKI which has been used in the pediatric setting. But of course, additional study later on addressed the question, is it dasatinib providing a better control of the disease and accordingly a better outcome with what has been achieved by using imatinib? This question was addressed by 3 independent studies. This was the original study from the COG by using a very intensive backbone of chemotherapy. And as you can see, in both the standard risk and the high risk Ph positive LL, the event-free survival, which basically measure the quality of your treatment, and of course you can compare strategy with another, was very similar in that study with with those provided by larger study in the use of imatinib. But then just in the 2020, a Chinese study, which has been conducted very well done and managed by our colleagues from the China's Children Cancer Group, the CCG-ALL 2015, addressed the question in a randomized manner whether by using the same type of chemotherapy backbone, the use of different TKI can make the difference. And they demonstrated that in their hands, the dasatinib provide a better outcome, especially for the control of CNS disease as well, relapse. Two major points about the study are the following. First of all, they did use a higher dose of dasatinib per square meter per day that was different from what has been now registered for the use in the pediatric and adult setting. And the other thing that was rather surprising, that the results of the imatinib was significantly inferior as the one reported by the Children Oncology Group and the ESFAL Consortium in Europe. More recently, and this is the study that was a pharma-driven study which provided the regulatory agency in the US, the FDA, and in Europe, the EMA, to approve the use of dasatinib in combination with chemotherapy for the treatment of pediatric Ph positive LL, clearly didn't show a significant benefit in terms of survival, again, EFS survival at 3 years as compared to the previous study, suggesting that apparently in this study, it doesn't seem to be a benefit to use dasatinib instead the original one, TKI, which has been extensively studied in the pediatric and adult Ph positive LL. So just to summarize, what we did learn so far are basically summarized in this slide. Two different backbone, the intensive chemotherapy of the either the COG and the ESFAL based on the IBFM high-risk blocks of chemotherapy, 2 TKI, imatinib and dasatinib, an overall event-free survival approximately of 70%. The majority of patients can be treated without SCT. There was no clear advantage on the use of the high-intensive chemotherapy backbone of the COG versus the ESFAL, and no clear advantage of imatinib versus dasatinib. So we still have the question, what is the best chemotherapy backbone that can we use for getting the best results with the lowest profile of toxicity in the pediatric setting? And this is the question which is currently in place and addressed by an investigator-driven study that I'm very pleased to chair in jointly with Louis Silverman from the Dana-Farber Cancer Institute at Harvard in Boston, where basically we address the question, can we compare the two different type of chemotherapy, the standard arm, which is basically the ESFAL, intensive high chemotherapy blocks of chemotherapy, versus the investigational arm, which is basically the COG high-risk ALL 232 backbone. And the study is ongoing. And just to give an update of the current status, because it's a transatlantic study between Europe and North American COG study. The study is running very well, although it was, can you imagine, a global investigator-driven study and with a very rare subset in many centers around Europe and, of course, on the COG sites in US, Canada, and other countries around the world. The first surprise that we didn't expect to be, according to the plan of the study, that most of the patients are basically standard risk, and standard risk are defined according to the lack of MRD detection after the first two cycles, the consolidation 1A, 1B, and the different blocks of chemotherapy for consolidation, suggesting that the intensity of chemotherapy plus the use of TKI can provide a very good control of the disease. Of course, the study is a non-inferiority study because the aim is to try to reduce as much as we can the toxicity profile that we learn is significantly higher in this subset of disease when we combine chemotherapy and TKI. This is already well known in the previous study. I'm just reporting the previous ESFAL European 2010, where basically at least 80%, so a significant proportion of the patient experienced CAE, and most of the CAE was infection. And of course, one of the critical issues from the clinical care is how to handle toxicity. And these are basically some suggestions that we jointly with our colleagues from the COG are very pleased to share. The reason being that as experience in the adult setting, but I have to say that from the pediatric perspective, we are not used to have so significantly high of toxic death for a chemotherapy, even intensive in the high risk, suggesting that the combination of chemotherapy plus TKI can really explain, because if you compare the same percentage of toxic death in the high risk non-pH positive LL as compared to the pH positive LL with the same chemotherapy backbone but plus TKI, the percentage of toxic death is significantly higher in the second group. What TKI? We are just discussing this issue. Apparently in the pediatric setting, it doesn't seem, with the exception of the results of the Chinese study, to be a significant difference between imatinib and dasatinib, which are currently the two TKI which has been approved by the regulatory authorities and accordingly can be used as a standard therapy in combination with chemotherapy. But of course, the key question, and this is even more important for the pediatric world and landscape, because if you ask the question to a pediatrician, I'm sure that the answer would be, we want to treat and to cure more, but with less toxicity. And that, of course, is one of the challenges that we are facing today. And in that context, of course, the aim to substitute the intensity of chemotherapy with the immunotherapy approach can be, as already shown, to occur in the adult setting, a very important perspective. And of course, the question is what type of immunotherapy dealing with the monoclonal antibody and CAR T as well. And this is, of course, you have summarized in this cartoon what are basically from the perspective of the pediatric landscape, the advantage of the blinatumomab versus inotuzumab to be considered instead of chemotherapy backbone. What are we doing? And this is a very novel and still unpublished because it's still working process. And I would like to thank our colleagues, Tai Hoa from the COG in Canada, who is currently leading the task force between European and North American countries to address the question, what is going to be the new generation of protocol for the treatment of pH-positive LL in children and adolescents? And of course, the question is, can we substitute the intensity of chemotherapy by using jointly with the TKI the Blina course? And of course, this is going to be addressed in a randomized manner. As you know, as a pediatrician, we are used to apply randomized study as the best way to proceed in our knowledge, although it might be challenging considering the rarity of this disease. The other important information I want to share is that, again, in the same line of our adult colleagues, we are already considering in the ongoing study. The one that I mentioned before is addressing what is the best chemotherapy backbone jointly between ESFL and COG. We have already decided as amendment to include the Abelson class fusion BLL, because we do believe, as all evidence suggesting, even with respect to the retrospective analysis of the outcome, even in the pediatric setting, that Abelson class fusion positive BLL biologically and clinically phenocopy pH positive LL. And accordingly, even in the ongoing, but definitely in the future, we are planning to include, and as you can see, between the 3 to 5%, we will add a 2-3%, which will be a significant, still relatively rare proportion of pediatric LL. One of the key messages I want to share with you that probably was one of the most important achievements of the current strategy, that only a minority, as you can see in the current study, less than 14% of children and adolescents, considering the molecular poor response to the treatment, are eligible in first line to receive transplantation. And considering that the most recent data on the randomized conditioning regimen question brought to our attention that despite of our hope, TBI is still the best of conditioning regimen for pediatric LL, as Christina Peters recently reported of the international study on the randomized question of TBI versus non-TBI regimens. This is an important challenge because we are fully aware of what are the medium and late long-term effects of TBI-based transplantation regimen. Can we use TKI after stem cell transplantation? As probably you know, even in the adult setting, the results are rather controversial because we do have a study that clearly showed that in the adult setting, patient transplanted in CR1, there was a more favorable disease-free survival on multivariate analysis, and it was associated with a lower common incidence of acute GVHD. By contrast, the CIBMTR, the consortium of bone marrow transplantation for North American centers, didn't show any benefit on the use of TKI for adult CML, so not pH-positive LL, but CML setting. So it's still controversial. And the current study in the pediatric setting is studying the feasibility of using in the post-transplant setting, the TKI in the high-risk pH-positive LL, who are the only one eligible in first CR. And again, I remember, a very low percentage, 14%, as compared to between 60 and 85% in the pre-TKI area. Of course, one of the questions is how I treat and how to treat relapse Ph-positive LL. And these, of course, are basically some clinical suggestions that, of course, highlight a few concepts. First of all, many patients who relapse Ph-positive LL have been successfully salvaged through reinduction and consolidation followed by SCT. And this, of course, explains the difference between an EFS of 65 to 70% and an overall survival of 80%, because a percentage of patients who relapse can be salvaged by reinduction. And of course, if you consider that today the reinduction can avoid the use of chemotherapy, thanks to the study which clearly showing the adult in pediatric setting that the 1 or 2 cycles of blina before, independent of chemotherapy or after a first cycle of chemotherapy can be the best way to achieve a remission before transplantation, provided an even more significant hope to further increase the results of this group. One thing I want to mention, different from adult, because we are in adult pediatric setting, is that the CAR-T can be, of course, considered as well. And more important, the last point is that children with PH-LL do not develop, or it's a very, very rare event of point mutation, even at the time of the relapse. Finally, let me discuss something which is unique and possibly, I hope, a matter of discussion, a very nice and extensive study from our colleague from Czech Republic, Jan Zuna and the CLIC group, reported a discrepancy between the MRD detection as assessed by the use of IG and TCR clonotypic marker, and as compared to the BCR-ABL genomic breakpoints analysis. Suggestion that by using this BCR-ABL genomic breakpoints, clearly identifying something different, persistence of the molecular disease. And this is clearly a very nice picture of his work. And actually, this been already, and the work is still ongoing, but soon to be published. They provided a European analysis with all the pediatric patient LL, starting by the discrepancy between the mRNA detection of the BCR-ABL and the IgTCR, and then in those cases performing a genomic breakpoint cloning in order to achieve a PCR DNA-based comparable of the Abelson fusion, BCR-ABL fusion gene as compared to the IgA and TCR. And what one possible explanation, and this is probably, I argue, something different from an adult setting, because if you ask the question, do you have cases of Ph-positive LL that a diagnosis can be considered blastic crisis of a CML? It occurs, but it's very rare event. And in most of the case, Ph-positive LL diagnosis are indistinguishable by all the de novo acute lymphoblastic leukemia. And so one possible explanation is to consider that the typical versus CML-like leukemia could potentially rely on the different type of target clone, which are basically interested by the events, as you can see in this cartoon, which clearly reflect what we can define the typical ALL. In this case, of course, a clone of lymphoid precursor can be probably the target of the genetic transformation. By contrast, in the typical CML-like, where basically you have the transformation with the BCR-ABL occur in a multi-progenitor, but then later on, the expression of the disease and the need of having secondary events, which can be the Icaros deletion gene, can basically be responsible of the pattern of clinical expression. So in both cases, you have a clinical expression such as lymphoid leukemia, but what is behind in terms of target cell transformation and occurring in a multi-step disease can be substantially differently. And these are basically my conclusion that I would like to share with all of you, thanking again for the opportunity. There is no doubt that even in the pediatric setting, targeted therapy has completely changed the landscape of treatment for Ph-positive LL. And the most important achievement is that only a minority of children with Ph-positive LL should be considered eligible for SCT, even because TBI regimen is still the option based on the recent randomized international study chaired by Christina Peters. Still open the need of use of TKI after SCT. New TKI can cover the need of targeting mutants, which I want to underline that is relatively rare in the pediatric setting. But finally, let me share that the future, and this is basically what we are planning to consider and to work with for the next future, is to replace the extensive need of chemotherapy blocks with immunotherapy, either monoclonal antibody and CAR-T, which we believe might further improve the cure while reducing long-term side effect. And so with these words, I would like to thank all the team. We are the largest center in Italy for the treatment of hematological and hem-onc diseases, including transplantation and gene therapy by using CAR-T. And of course, we are welcome, and I'm personally welcome to answer the question that have been presented. Thanks again for the invitation. With my best.